arrangements and things to do afterwards and traffic in downtown Austin, that it would be more beneficial for our group if we met the week prior. So that is the direction that we're going. And we're planning that you're going to go with us. Any questions about that?
What days would that be the GETAC meetings on?
The GETAC meetings will be on November the 10th, 11th, and the council meeting will be on the 12th, the evening of the 12th. This will be a one-year only change that we're going to do this. We expect to be back on the regular schedule in 13. And again, it will be here in Austin.
For the council's consideration, I went ahead and told them to move our meetings with the conference. If the council wants to discuss that further, we can put it on the next agenda, but it seemed the most logical thing to do.
Okay.
I've never been to a Formula One race.
We have the meeting there.
Exactly.
Seems like they might need some EMS to too.
Sure, paramedics and a few docs wouldn't hurt anything. Nurses.
Okay, the next thing I'd like to talk to you about, I think last time we talked about the progress of the rules, and I believe Mr. Matthews asked for a little more information as far as what type of suggestions we got from committees. And in your packet you will find 24 pages of suggestions that we got. And remember, these are being termed suggestions. They're coming from the committees. What we ask is that each committee review Chapter 157, and through the committee process, so that means that their committees have vetted their suggestions and then make those suggestions to the department. Just as a brief summary, we had 5 committees that actually submitted input. We have 2 of those are very extensive submissions, for a total of 6. One committee provided forms and rewrites. For subsections and paragraphs, revisions that were suggested, we had a total of 476 suggested revisions. And we actually had a few people, we had about 24 individual comments that we did take and archive. There were a fair number of sections that had no suggestions to them. The most popular one was for provider licensing, 157.11, and the designation section, section 125, stroke 133, and I guess the next was probably disciplinary provider actions, around 12. The process as it stands now, all the suggestions are in, and it is up to the department to work through and develop a draft, and then get the draft back out to the stakeholder group for review before it comes up through this council. So hopefully when it comes to you, you will have a very good, solid draft that has been through the vetted committee process. Any questions on this?
Just to clarify, the comments came out of committees and by individuals. They come to you, you modify them to where they'll, or amend, edit, whatever, so that they're in compliance with state law and the capabilities, and then they're going back to the committees.
Correct.
And then the committees will review and approve that, then it comes to council.
All right.
Okay, thank you.
What I'd like to do is have a joint meeting of all committees, probably be 2 days, and go through the entire set so that everybody hears the discussion from every side.
I just want to say thank you for doing that. It makes it much easier to kind of have an idea of where everybody was at, so that when you kind of get phone calls and emails and people wanting to know if their concerns were in the process, then we have a list, and I appreciate you doing that.
You know, what we've been telling the committees all along is that give us all your suggestions. Whatever you want to give us everything. Even if we've told you in the committee meeting that we know that's not going to get in because we're limited in some way and authority-wise, but go ahead and put it down, and we can respond back to the suggestions and say, you know, by statute we're limited on what we can do with this. This exceeds it, because I think everybody's ideas and suggestions deserve that type of response from us. So that's what we are intending to do with these suggestions. Okay. And as far as a time frame, I'm not real sure. It just depends on how quickly we can work through everything. There are goals on trying to get it done, but I can give you a better idea maybe in May as to what type of timeline we're looking at. Okay. And beginning in, I believe, March and April, we're going to have town hall meetings. Are you starting March? February and March. Apologies. There'll be February and March. Mr. Bishop and the EMS managers will be traveling around the state doing town hall meetings for EMS providers. This is an open forum where there can be discussion of the current rules, how they impact individuals, and it's a great opportunity for the EMS firms and individuals to come and talk to the state about how whatever questions they have in the compliance with the requirements. And when's your first one, Maxie? February 21st in the Houston area. There is a list on our website, so if anybody's interested, just pick one and go to it. I encourage anyone to attend. I went to the one that they did, I believe it was last year in San Antonio, and it was packed, standing room only. I was thrilled to see that they have an auditorium this time for San Antonio. So, okay. Moving on to the funding report. As far as trauma designation, we currently have 257 designated facilities and 24 in active pursuit. We have 87 stroke facilities. 86 of those are the primary or level 2 designation. We have one currently designated level 3, and we have we have recommended 24 additional level 2s that those designations have not come back yet as approved. We currently have the fiscal year 12 appropriations for the uncompensated trauma care was $57.5 million. That application was opened in November, and it is due back from the participating hospitals February the 14th, Valentine's Day. And for any hospital that is participating in the Medicaid standard dollar amount trauma add-on, we still need their uncompensated trauma care application through our office. So we've been working with those facilities. They are coming in, sending in their applications daily, and our staff is working with them to ensure that they get all of those things in and that they meet our deadlines. I think on the cumulative for that fund, we've had to date, we've distributed $447.5 million through that grant process. For our EMS, our local project grants for this year, For 13, we're expecting the request for proposal will be available sometime in April. Contracts are estimated to begin in October or November of 2012. You know, last year we had 136 applications and we funded 124. For ECA training for fiscal year 12, we have $25,000 available. We've currently funded 4 ECAC courses, and we have a remaining balance of $10,506. On our EAF funds, that's our extraordinary emergency funds, we had $1 million for fiscal year 12. That was available 9/1. We've funded 2 EAFs, have been funded so far. We have a remaining balance of $958,000. Do you have any questions on the fundings? That concludes my report.
Thank you. Dr. Valadez?
Good morning, everybody. I'll try to make mine fairly brief. It's just 10 pages. So here we go. First of all, I just want to give you an update on our EMS Trauma Registry project. It continues, as you know, to be a high priority with our department. We just met the other day on that. It's fully funded through the Texas Department of Transportation and with matching funds from our agency. And we're still on board to go live on August 2012. We do want to make a note of a project staffing change, and I want to introduce to you Mr. Robert Klein, who's right behind me here. Mr. Klein, he is our new EMS Trauma Registry Replacement Project Manager, and he'll be overseeing the next critical months of implementation. Mr. Klein is a certified project management professional and has been a member of the Project Management Institute since 1998. And he's successfully managed projects for IBM and other large corporations since 1995, and we're very happy to have him on board and continue with our progress. We're still completing our modeling phase. Actually, that's been complete, but as you know, the flexible nature of this product with Consilience, we continue to update the model with the NEMSIS changes that were recently released. And the modeling activity, just so everyone is aware, is absolutely essential to building the workflows that you'll be using and the reports for the new system. It's really where those data elements and valid answers are created, so it's a very important part, and we're continuing with that. We also have been working with our IT staff and Consilience, who's our software vendor in data conversion. And this involves reviewing data elements in the current trauma registry and working and mapping them into the new database. And again, as you know, this is a huge, large database, and so that's been taking a significant amount of time, but we're moving through. And it also requires a lot of checking and cleaning of old data to ensure that good data is migrated into the new system and that there's a perfect match between values in the current and new systems. And then in the November meeting, I think we mentioned NEMSIS released version 3.1 of their data elements, and we continue, and they continue to release additional ICD 9 and 10 reference lists. And so as these lists are released, we're working to map them into the data map of the new trauma registry. And then we're also been working with you all and other stakeholders to pursue a web registration interface. This is basically to facilitate the ability of facilities, both EMS and hospitals, to register and update their information in the system. This will replace the time-consuming current manual process that reporting facilities and department currently use, and so I think this will be a big win for everyone. But because of the high priority of that web facility registration interface, its implementation will be immediately after go live in August, so around September timeframe, we hope to have that ready to go. And systems enhancements not related to data collection, we're going to shift those out a bit to after the web interface is put in place first. So for example, some of the data linkage functions to external databases, we might postpone those until after we get that interface built. And again, we'll work with the stakeholder group to prioritize that and schedule that. And then our Stakeholder Registry Solutions Work Group, they're currently reviewing our DSHS Injury Prevention and Control Rules, which is under the Administrative Code, Chapter 103, and will present their recommended changes to GETAC at a future meeting. So we're undergoing the rule review process, and they're actively engaged in that. And we continue to hold webinars for our stakeholders on that new registry. The next webinars are scheduled for February 21st and 28th, and these will focus on stakeholder feedback regarding the injury prevention and control rule changes. So there's an opportunity there. Switching gears but related, and on our health promotion, chronic disease prevention side, with cardiovascular disease and stroke updates, our Texas Council on Cardiovascular Disease and Stroke quarterly meeting was held just last weekend. There we announced our winners of the 2011 Heart and Stroke Healthy Cities Award recipients. This is a recognition program recognizing communities, cities, for making changes in their systems, policies, or environmental changes to promote best practices and put them in place to promote public health priorities for reducing cardiovascular disease and stroke. Gold level winners, Marshall in Harrison County, Tyler in Smith County, Nacogdoches in Nacogdoches County. They've done some great work. At the silver level, we had communities in Temple, in Bell County, and Bryan in Brazos County, Georgetown, in Williamson County, and Longview, and Gregg in Harrison counties. They've done some tremendous work to improve outcomes for cardiovascular disease. And then lastly, the bronze level, Harlingen in Cameron County, and Odessa in Ector Midland County. And awards will be presented by our council members to each city in the spring. We are still seeking applicants to serve on our CVD and Stroke Council, and certainly if you're interested, please contact the Governor's Appointment Office or me, and I can direct you to the right place. And then we're continuing to work on a plan, the Texas plan to reduce cardiovascular disease and stroke, and that's being developed by the Texas Cardiovascular Disease Partnership and our council and our agency and other stakeholders. And so again, if you want to be involved, please let me know. One note, I as a part of this, recently we received a Community Transformation Grant Award to the state of Texas in this area for preventing cardiovascular disease and stroke and other leading causes of death in communities. This was a $10 million per year award for 5 years, so $50 million to the state. We're very excited about that. The award was received in the early fall. We had an RFP out and released the awardees. There were 18 counties 18 entities serving 30 counties across the state and every part of the state to begin to transform their communities, unrelated to the Medicaid waiver, but another nice adjunct to really begin to create those systems, environmental policy changes, community changes needed to prevent cardiovascular disease and stroke. And so we're very excited about that opportunity. And certainly going to be reaching out to many of y'all to help us as we roll that project out over the next 5 years. And so we pushed out $6.4 million to small to medium non-urban communities and rural and frontier communities, and so we're excited about that. And then lastly, on the preparedness side, we continue to hear and get information about grant alignment between the hospital preparedness program and our public health emergency preparedness program. That funding opportunity announcement will be expected to be released in March, so not too far away. States, what we're hearing is that states will be submitting one cooperative agreement for a 5-year project period. And then the states will be receiving the funding from both entities, which Office of Assistant Secretary for Preparedness and Response is where the hospital preparedness program comes from, and CDC, the Public Health Emergency Preparedness, is where the other funding comes from. So we'll receive both streams of funding, but under one federal announcement for funding. And as part of that, we continue to do risk assessment and capabilities planning, which are a cornerstone for these applications. There are 8 capabilities for healthcare systems preparedness and the development of healthcare coalitions and assuring recovery through continuity of operation plans. So that's going to be a big focus for healthcare systems, and they're going to be in that next ASPR 5-year period. Because of this change and this alignment, what we're going to do is just extend the existing hospital preparedness program contracts with the RACs for 1 year, so that we let the dust settle on this alignment and see where we end up. And then we probably would be releasing a new RFP for hospital preparedness program under this new funding announcement. And it'll be expanding to what's being called healthcare system preparedness and these funds would probably be issued in FY13. So again, certainly as we get more details, in fact, in the next few weeks in Anaheim, California, the Public Health Preparedness Summit will occur, the National Summit. Our director, Bruce Clemens, is over here, and some of his team will be attending there. That's February 21st through the 24th, and we certainly expect there's going to be a whole session on the grant alignment and the future shape of how hospital preparedness programs and the public health emergency preparedness programs will be aligned. So we'll keep you well informed of that, of the outcome of that meeting. Again, I want to reiterate, the hospital preparedness program will remain a distinct program. They're just aligning the funding announcements for this and doing that. But we'll learn more in the coming weeks at the Preparedness Summit. And then there will be a joint conference or summit in Atlanta between the public health emergency preparedness side and the hospital preparedness program groups to, again, begin working through more details of this grant alignment. So as we learn more about it, we'll update you all and assure that everyone is in the loop on what changes may be coming to Texas related to that. And certainly, as Kathy has mentioned before, we want to assure that all the tremendous amount of work over the past decade that has gone into not only the trauma system but the disaster response system, as was highlighted, is not undermined and continue to be built upon, enhanced, and that would be our top priority. So that's what I have for this morning, and if there's any questions, I'd be happy to answer.
Any questions from the council for Dr. Valadez?
Not a question, but a comment. I wanted to thank you for having somebody from the registrar to come to each of the committee meetings. That is extremely helpful to answer ongoing questions.
Great.
I found that very, very helpful. Thank you.
Thank you for that feedback. We'll continue to do that. Thank you.
The only question I have is, if, depending on what happens with ICD-10, is that going to change our ability to have the registry up and going?
No, again, our go-live date is August of this year, 2012, and then we are aware of those reference and table list changes that are coming, and I think our plan was to then update after the go-live date in future years. So that might be a future bell and whistle, if you will, and I think, I don't know, Tammy or Ron, if you have any details on that?
Hi, I'm Tammy Sajak. We are going to be able to continue to receive the legacy data that has been currently sent, the same file format as ICD-9. We will have a transition period before we require people to submit the new format to us. We have a question modeled in our new system that asks whether you're reporting ICD-9 or ICD-10, so you have the capability of reporting either of those. And we'll continue to have that capability until everybody has transitioned over to ICD-10.
Thank you.
Any other questions?
I have one related to the EMS function of that. When do you feel like that vendors of electronic patient care reporting will be able to start building patches to the new framework?
Good question, and I'll have to turn it over to Tammy probably again. Sorry, Tammy, just stay up there.
Usually they don't start building the new systems until after they have tested everything that they've already got in place. So for EMS, it's really contingent upon NMSIS. So every week, NMSIS has a telephone call, and many of the vendors are on that telephone call, working with them to test out the new things that they're saying they're adding to the system, give them feedback, and NMSIS and this group is going back and forth and making changes. So until they sign off on all of the changes and have done some testing of that system, until then they will not release all the specifications for updating everyone's software to be, we're up to NMSIS 3.2 version now, so to be up to that version specifications. So we're thinking that we won't be able to probably have those specifications until towards the end of the summer. And then we'll be giving everybody plenty of time to work with their vendors. DSHS will work with the vendors, and our company Consilience is also going to help us to work with them on the new file specifications, be doing testing with them after they have set up their initial file submission format. But we need to have some user acceptability testing of our new system before it goes live. That needs to happen in conjunction with us releasing what the specifications are.
Any more questions? Thank you, Dr. Valadez.
Thank you.
We'll now move into GETAC committee summary reports, starting with the Air Medical Committee. Shirley?
Good morning, everyone. The Air Medical Committee met yesterday morning. We had a few items to discuss that we've been working on for a few meetings, and we'll continue to work on those because we're not up to solutions yet. We are still looking at the recommendations for including language in the Texas Administrative Code that will include acute care along with the STEMI and stroke so that we are ensuring that the needs of our patient care needs are being met. We are continuing to work to look at the language to include in there if there is any. We had a discussion on the utilization of aircraft by ground EMS regarding the appropriateness of use of aircraft. That stems from a letter that and a presentation or a request that we had from a customer that felt like he had a family member that was inappropriately transported. So we're looking at some utilization guidelines. One of the things that we are going to use in the future to help, maybe hopefully with some of that utilization review, will be the model state guidelines that are being worked on by, it started at NASIMSO. The Association of Air Medical Services has a group working on the air medical piece of that. My understanding is that there is a draft that is ready or will be ready pretty soon from the Ames group anyway. We should be able to get a copy of that draft so that we can review it before our next meeting, maybe have some pointers from that draft to see what we're going to come out with there. So we intend to use the draft as much as possible. We'll do a gap analysis of the draft and what we have, and then maybe we can also use that draft to look at other issues such as provider responsibilities and those kind of things. And then we had also, we are going to enlist the help of the Texas Association of Air Medical Services, our state group, get them to assist us then with some aircraft utilization work with the EMS committee, try to get some of those issues ironed out. And that's what we'll be doing for the next few months until we have some solutions.
Any council questions for Shirley? Okay. Next, we have Cardiac Care Committee. It says Dr. Peirce on the agenda, but I believe it should be Dr. Smalling.
Thank you very much. The Cardiac Care Committee was called to order immediately following the joint meeting between with the EMS and medical directors, and I'm going to defer a report from that joint meeting to Dudley Waite, who's the chairman of the EMS committee. We presented data at our meeting from national meetings and presentations of national registries, and Dr. McCarthy, Jamie McCarthy, had done an analysis of 23,000 STEMI patients transported by EMS to hospitals from the NCDR registry, which is part of the HA Action Registry. The in-hospital mortality rate in those STEMI patients, and the participating centers are really top-line centers, was 7.2%. And the incidence of cardiogenic shock on arrival to the STEMI center was 10%. So these are not small numbers and much larger than had been previously suggested. It's 23,000 patients, so it's hard to argue with the data. They also found that on average patients contacted the EMS about 50 minutes after onset of symptoms. So it was a fairly rapid call, and 65% of the patients with STEMI contacted EMS for transport, which is a lot higher than has been reported previously. The patients who walked into the hospital had a in-hospital mortality of about 2%. So the feeling is, and it's not yet worked out, was the people that were sicker tended to call EMS, and the people that felt not to be so sick drove themselves in. There's been a national initiative to decrease the door-to-balloon time, the time from arrival of the patient in the hospital to inflation of an angioplasty balloon in the infarct-related artery. That's been very successful. Average times have decreased nationally from about 120 minutes to a little over 70 minutes, which is a big improvement. Unfortunately, at the same time, the mortality rates have been the same. So this effort hasn't paid off. The other data that's been reported is, in order to get a beneficial reduction in mortality and a decrease in the size of the infarct measured by cardiac MR, you have to achieve reperfusion within 2 hours from onset of symptoms. And since the average patient gets treated by balloon angioplasty 3 to 4 hours into their course, you can't expect balloon angioplasty by itself to be successful. 3 separate studies, one randomized, showed that in patients treated pre-hospital or pre-transfer with reduced dose or full dose fibrinolytics, followed by an emergency angioplasty immediately on arrival to the STEMI center, the mortality was about 2 to 3%, and the incidence of shock on arrival was 2%, which is dramatically better than what's been reported from the previous reports. In Houston, we unfortunately had to suspend our pre-hospital treatment of patients with fibrinolytics for a variety of reasons in January of 2010, and we've tracked our results since then with the same system in place. In other words, the patients are identified by EMS. We activate the STEMI team from the field. The times, the medical contact to balloon times are the same, and our mortality has increased from 2.7% to over 11% in hospital. And the shock on arrival rate has increased from 2.5% to 20%. So all of these data are suggesting very strongly that we need to move STEMI treatment into the field, probably with some form of lytic therapy in addition to aspirin, clopidogrel, and heparin. So that we're in the process of putting together a randomized trial to do that. Lonnie Den from AHA presented the data from the Action Registry comparing Texas outcomes to national outcomes, and by and large, Texas is doing as well or better than other national comparators in terms of STEMI care. The main disparity is in patients who are transported. The first medical contact to balloon inflation times are more prolonged in Texas, and you can imagine transport distances are longer. So that's one of the major opportunities it was felt to improve that. And again, enactment of a strategy of lytics in the referring hospital prior to transport might be a potential solution for that. 80% of the patients who get lytics before they get to the hospital have open arteries by the time they have their first angiogram, and that's also correlated. An open artery at the first angiogram is correlated with a significant improvement in survival and better performance status. After the action data were presented, there was a discussion regarding potential projects for the coming year by the committee. There was a lot of discussion about getting information from the local RACs about their STEMI care efforts and how they are doing. The committee suggested that everybody would think about data points we would like to see, and then we would transmit them to the RACs to request voluntarily that they report their outcomes for those individual points. There was also consideration of distributing information on best practices to the RACs. We talked about wet mailings and so forth. There's no budget for that, as Jane will tell you. So one other possibility would be for the committee to submit information to be posted on the website of the Cardiac Care Committee and email sent to the local RACs saying, if you're interested, here's the latest literature in STEMI. We have representative case reports from various areas that might match your area in terms of whether it's rural or urban, whether there's long transport or short transport, advanced pre-hospital treatment, not, and so forth. And so those vignettes were being assembled. Dr. Purse mentioned that many of the hospitals in Houston, once they receive a STEMI patient, transmit back to EMS and the whole STEMI team what happened during that case when the patient was picked up by the paramedics, what the ECG looked like, what the ECG looked like after reperfusion, what the ECG and the angiograms look like. They include bits of the angiograms for the paramedics and others to see, and then good points and opportunities for improvement. And that's distributed to the paramedics, and it's useful for training, and it's also distributed to the STEMI team, which is helpful for improving process at the hospital. So all of those issues were discussed. There was finally a public session. There were two main comments that I distilled. One was it would be nice for the local RACs to have access to success stories so that they could begin to see how they're doing and what they might do to improve things at the local level, all voluntary. And then finally, someone from San Antonio stood up and said there's need for state legislation to regulate STEMI care similar to stroke and trauma. And that concludes my report.
Thank you. Any questions for Dr. Smalley? Thank you.
Thank you.
Disaster and Emergency Preparedness, Eric Epley.
Good morning, Chief.
Good morning.
We met on Wednesday for about 90 minutes, followed on for another 2.5 hours after that. We have long meetings. We had 75 to 100 people in that room. I want to thank people in this room and the people who participate on the disaster committee from across Texas. When you see that we've been doing this effort for about 4 years now, and we're still seeing 75, 80, 90 people sitting around talking about disaster preparedness for 3 and 4 hours at a time, I think it says we still have a lot of work to do, but there's a lot of dedication. So I want to thank all the participants and the committee members. We're going to have a social media lecture that didn't happen today, but we're going to do it in May. I would encourage everybody who can to come to this social media lecture. There's a guy named Locke Mullen in Fort Bend County, and he's the PIO. I tend to think of social media about how to put messages out. This is not that lecture. It's about intelligence gathering and the tools that are available for Twitter, Facebook, all the things that are going on, about how we can glean intelligence in real time about our own community. So if something happens, we can watch that with geographic boundaries and be able to use some search capabilities that I frankly didn't. It just looks like drinking from the fire hose. And when you start to see these tools that are easily and freely available, you can see how Twitter and those things can be a little more manageable to provide us in emergency management some capabilities that I didn't know we had. We'll have that lecture in May at the GETAC meetings. We had an EMTF briefing from Victor Wells, who is the project manager on EMTF program. We currently have 4 buses in place now. They are either licensed by DSHS or are underway to be licensed shortly. We have 3 that are fully licensed and 1 that's in pursuit of that. By July, we should have 13 of the AM buses in Texas. There will be one AMBUS at least in each EMTF region. 13. Still up to FDNY, about 27 of them, so we're still behind them, but we're working on it. MMU development continues. I think that's an effort that's moving faster than I would have expected, and almost every EMTF now has at least the ability to put an MMU up in their area. They're still working on the staffing and the other capabilities, and they have a graduated approach to that. The RN strike team component of EMTF, it still continues to struggle based on some liability issues related to some of the big health systems. Denise Rose from THA is helping us with Scott and White, some counsel there that's providing some pro bono work, so we can craft the language that will be effective for meeting everyone's needs on liability concerns. We had a briefing on our EMTF governance. I think I showed you that last time, and we were going to move forward on that. I think that this meeting there's an EMTF governance that you guys accept that and kind of move that forward. And we are going to change across the board our words plan to standard operating guidelines, to SOGs. Because there's so many words plans, like, well, this isn't in the plan, that's not in the plan. It's like, which plan? And it's a siloed plan, and so the word plan actually causes some discord in our world. We don't know whose plan we're talking about. So we're going to use a different word, make it a little bit easier. At least we'll know we're talking about SOGs instead of plans. Maybe that'll solve it completely. We had a briefing from the Houston Regional Catastrophic Planning folks on their AMOPS, and the fascinating part about this is it was a parallel effort to EMTF that we didn't really understand. And what it's turned out to be is a template or a model for all EMTF regional deployment in Texas. We're going to be working with those guys over the coming months, and we're very excited that EMTF can be your neighbor's neighbor, can be that regional mutual aid response, and it can be a state response as well. Dr. Mitch Morber presented his disaster medical care with scarce resources. That work product has had over 50 people involved in it, and that's very much near completion. It's in draft form right now. I would recommend we move that to the Texas Disaster Medical System Committee and allow them to work with Dr. Lakey, Dr. Valadez, and others. There's several regional efforts that are underway in the Dallas area, the Houston area, and others, and I think there's an opportunity for us to start to coalesce all of these plans and find best of breed and work for a common document. That's pretty much it. I'll entertain any questions.
Go ahead.
Eric, does your committee have plans to publicize your preparation?
So, yes, ma'am.
Okay.
We have some vignettes, small little video vignettes on EMTF and other things that will be helpful for the provider, but also would explain it to the lay person. More importantly, and more, I think, to your point, is how does the community know at all about any of this stuff? And DSHS has done a wonderful job with the texasprepares.org website. And they've produced videos that are very heartwarming. They deal with people who've been through disasters, and it kind of walks you through the steps so that you see the real impact. We saw some of those videos here a couple of meetings ago. They're available for community outreach efforts, and you can get the videos themselves, but you can watch most of that online. And they're in Spanish and English, and I think there's like 4 or 5, 6 of those sets of videos. So they're great for a PTA meeting or for a fellowship hall night or something. So also, really local disaster people should be putting that word out. Sometimes there's some pushback from local emergency management folks when the state starts providing lots of information to what they consider their people. So we try to channel those efforts with the tools and capabilities, but allow those local communities to reach out to their folks individually with disaster fairs and other community efforts.
Thank you.
Yes, ma'am.
You can go ahead and load the gun, but I think there was something that was supposed to have been on our agenda from last time.
That was the EMTF governance document that we had.
EMTF governance.
For May.
Thank you so much. I appreciate that. I apologize for not making sure, but I've got a big star by it this time.
No problem, sir.
Education Committee, Jody.
Thank you, Mr. Chairman. Education Committee met on January 27th in Saxe, Texas as part of our work group. We did have a quorum that day, so we were able to conduct business. One of the things that we looked at was the discussion of transition courses, and that is the content for personnel to maintain the National Registry certification. One of the questions that the educators have been knocking around for a while now is that does the NREMT option of using all the card courses, BLS, ACLS, PALS, PHTLS, AMTLS, AMLS, all of the alphabet courses, does this meet the CE requirement for the transitional material? And one of the things that we looked at and actually voted to move on to DSHS was that if we would ask DSHS to establish some common language, because we feel that if the program has already been teaching the new 2009 National Standards curriculum, that if they would reflect that on their course approval, on their course completion certificate, that would probably be the easiest way to report that. And for those people who are doing CE, that we have some standard language at the bottom of the CE material showing that they've already covered that. One of the things, too, that the committee was curious about, and we've also asked DSHS for some information here, is that we were asking for a frequency distribution report from DSHS. As educators, we're just curious now, because remember in Texas we have, I guess you can call it the 4+1 option for recertification. How many people are taking the exam? How many people are using CE? How many people are taking research refresher courses? How many people are using National Registry? And do we have any programs using CCMP or the Comprehensive Clinical Management Program in order to research? I think we've been doing this since 2004 now, so we probably have a little data there that we're asking for to see which one of those options that most people are using, and then use our resources for CE to support the options that seem to be working the best. So we'll be taking a look at those and probably going back to make a revision in 15738 to try to match that policy. There was some discussion yesterday, obviously, cardiac, EMS, and medical directors. While you'll find that most educators and most professionals think that going National Registry makes sense, there are also some issues that go with that. And we'll be sitting on the sidelines for a while until we are needed to take a look at that. Right now, certainly, we would encourage anyone that has it to maintain it and keep it. The thought of getting those people who are not there yet will be a task that if we as educators need to support our brethren and sisters in, we will. One of the things that we also looked at too was development of a checklist to assist the EMS coordinators in their transition courses. And we have asked Ron Wolford from Methodist Dallas and Brian Erickson from Tarrant County College to prepare a report to the Education Committee that they will present at our April work session to look at each level and figure out how many hours we think that from EMR all the way to paramedic, how many hours transition should be included. So we'll get that from them. Also, we looked at some clinical items, some issues ranging from clinical guidelines that may or may not be clear, some clinical guidelines that may or may not be written, why some institutions are having difficulty getting their students in, especially operating rooms, for the clinical experience. And I think we've all been talking about this for a while, but we're going to see if we can take it on and try to establish cause and effect. Dr. Villers will be working up a survey that will be going out to the RACs to examine those level 1s, 2s, 3s, and 4s that have students at their facility, how the educational process is going from the hospital perspective. We'll then take that and modify that with the EMS perspective and see if we can come up with the common ground and or common issues and see if maybe rewriting some of the objectives and changing the educational process will actually help them, and we'll be working from there. It's probably been a year and a half, and the Education Committee finished the Education Training Manual, and we went back to add verbiage for 15732 for the accreditation of paramedic programs to add that to the manual. And when we realized that Mr. Lockwood had not received that update that we did a year and a half ago. So we fell on our sword yesterday and apologized to Phil. And I think Phil now has that document probably several times via email along with the new information in it. And I apologize publicly for that because I think we just assumed a year and a half ago that when we finished it, he had gotten it. We also had some public comment on who are EMS instructors and what the qualifications are, and this seems to rear its ugly head every couple of years. When we look at our counterparts over on the fire side, we look at our counterparts on police side, looking at their requirements and will they accept ours, because we have a lot of people in public safety who cross over who are sometimes hold 1, 2, or all 3. And some not being allowed to teach and some others. So we're taking a look. We've asked Jeff McDonald, actually appointed Jeff McDonald from Tarrant County College and James Shiplett from Collin College to help us examine and take a look at credentials of instructors in multiple areas. That is just doing skills, that's doing didactic, that's program directors for basic, that's clinical coordinators, just to kind of give us an idea of the credentials of personnel who are actually out there teaching, and they will present that at our April work session. Our next meeting will be I believe it's April 13th here at the Learning Resource Center here in Austin at 9. We'll still have the instructor rule CE and the transitional documents on our agenda. Also had the opportunity to present plaques to those people who missed the EMS conference. As many of you all know, the Education Committee received the EMS Educator of the Year award, and I can tell you on behalf of the committee, I know I was stunned. I think everybody on the committee was stunned. The one thing I just want to thank everyone publicly for is the acknowledgement of that extraordinary group of people who have taken their time, effort, and their money to travel all over the state to support the advancement of EMS education in Texas. Was absolutely extraordinary. So some of the people that were not at the November conference received their plaques yesterday, and just on behalf of the committee, thank you.
Any questions for Jody? Thank you. EMS Committee, Dudley Waite.
Good morning. The EMS committee met yesterday right after lunch. We had an abbreviated meeting because of the joint meeting you've been hearing about. Commissioner Perkins was at our meeting as well and presented the information that she presented to y'all. And then she was kind enough to stay around because that item was on our agenda as well for our agenda item number 4. So she stayed around for that discussion, which we basically opened up the floor to the committee as well as to anybody that was in attendance to talk about ideas or various other issues that they had seen out there regarding these large increases in non-emergency transport providers in the more metropolitan areas. We had some really good discussion. A couple of things that came up. There's some folks that are concerned. Seems to be a new, I guess I'll use the word cottage industry that is developing in some of these metropolitan markets for what is being called EMS consultants that are coming out for the right fee and delivering packages that are ready to be turned into DSHS that include personnel lists, medical direction, protocols, everything but the checks that need to be written to make the thing happen. And there's some questions made about whether DSHS had the ability to regulate those folks, and currently they don't, but some of the things they may be doing may be putting these providers into a fraud issue or a potential issue of not being necessarily accurate in their packages. One of the other things that came out during that discussion is some EMS directors around the state have started reporting to have started to report that some of their medics are being approached at emergency departments and other facilities when they're on duty by, not really sure by whom. We're assuming it may be some of these EMS consultants offering them $100 here, a couple $100 there to put their names on these personnel lists for some of these agencies so that when they turn them in, they'll have bona fide certified paramedics on their list or EMTs on their list. And so that was very interesting to the DSHS regulatory staff who are looking at maybe even making some changes to some of those forms where the medics would have to attest that they are working there so that if it was proven that the medics were doing that, action could be taken against the certificates as well for playing a party to that. So it's a pretty complex issue. We also talked about city ordinances. Municipalities have some ability to control some of this, depending on how large it gets and how out of control it gets. But the problem that starts to develop, and I think one of the things that hopefully some stakeholders will step up and start working to address, is that if you have 20 suburban communities around a large city, and those suburban communities pass 20 different ordinances and regulated non-emergency ambulance providers, and the legitimate providers that are needed to move people from point A to point B every day are going to find it very difficult to exist in that environment where they're having to meet the requirements of 20 different ordinances that may be 20 completely different requirements on them. And the cost of doing that may actually harm the folks that are out there doing the services correctly and attempting to play by the rules. So it is a complex issue. We're excited by some of the things the Texas Medical Board had to say, and there's a lot of stakeholders working to come up with some solutions to this. So hopefully more of that will be forthcoming in the coming weeks. We got the report from Jane regarding the Chapter 157 rules and regulation review, and I'm looking forward to that. We had a report from EMS for Children. They have a medical director survey that is out and open, and they're going to be sending multiple reminders. So if you hear of EMS agencies or medical directors getting more than one of those, it's because they don't know who's answered the survey, and they're trying to get broad participation. So they're going to keep pinging the bell until hopefully as many medical directors as possible answer that survey. And then they've also come up with some equipment based on their last survey that they've had granted, and it's off the list of needed equipment on ambulances, mainly aimed at neonatal, but also some pediatric populations, that they're going to be working with the RACs to get distributed to agencies that don't have that and can't afford to get that, bag valve mask, end-tidal CO2 things, and stuff like that. Let's see. We also had the discussion regarding air medical and ground providers on the scene. This is like Shirley said, this is a kind of a complex issue, and each time it came up in a different committee, another scab was picked off, and we found some more bleeding. So it's a whole host of issues regarding who has responsibility when, who doesn't, who's coming in to take the patient, who not, are they coming in from out of state, are they in-state providers? It just gets very, very complex, and so the EMS committee is going to continue to follow up on this. I know the Air Medical Committee is as well, and I believe medical directors probably will continue to at least discuss this as it goes forward. And then that was the end of our EMS committee meeting. We then opened up the joint committee between us, cardiac, and the medical directors. And Jody, my apologies for not including your committee in that. That was an oversight on my part, but you won't be sitting on the sidelines in future discussions on that. You're going to be right in the middle of the melee. It was actually very good. I thought it was an excellent discussion. A lot of really good points made on both sides of the issue. Jody was exactly right. This is not an easy, should we do it, should we not? Yeah, let's do it. Let's pass a rule and do it. It's a broad issue. And so we had a presentation that we did up front that kind of compared National Registry to Texas and what it takes to recertify, what are the methods to recertify in each of those, and the costs involved in that. Dr. Peirce, who sits on the National Registry Board, then presented some numbers showing where National Registry is used for initial certification and where National Registry is required to be maintained. And then he gave some insight into what he thinks will be approved very shortly, in bureaucratic terms, I guess, within the next year and a half, probably, of a new way of not a new way, but a modified CE recertification plan through the National Registry, where they're going to actually drop the number of CE hours they require every 2 years from 72 to 60, make half of those or 30 of those hours be core content hours, like the majority, at least for paramedics, are now. 15 of those hours be driven off of the agency's QI/QA findings. So what is it that our agency needs to educate our medics on, because we're not doing a very good job with. And then they're developing a self-assessment tool where the National Registry certified people will log on, take that test, and based upon that test, it will give them an outline of 15 additional hours they need to take based upon their own individual needs as certificates. Sounds kind of cool, sounds kind of space age, but it intrigued me as a National Registry certificate holder that my CE requirement was going to go down, and that there may be a tool to help me focus that instead of just take these classes and go take these classes and this is all you can take, and it's the same classes I took 2 years ago and 2 years before that. So it was very intriguing. The EMS committee also made several recommendations you'll see as you look through the packet that Jane gave you regarding CE requirements going forward, as well as regarding some different changes in the core content that Texas requires, and some other things like that. So they both of them seem to be moving along in I don't want to necessarily say parallel, but they're both moving forward in new ways of causing this recertification. So we talked for a full hour. Actually, we talked a little bit longer than an hour, and we invaded some of the cardiac committee's time. But I thought it was a very healthy discussion. We've asked DSHS for some numbers. I know the Education Committee asked for some numbers about who's using what recertification method, how many people every 4 years are using those certification methods. And then we've asked Maxie to see if we could determine how many of the current certified people in Texas are also maintaining their national registry today. And so if there's 55,000 certified people and 54,000 of them are maintaining their national registry, it seems like a no-brainer. But I don't think those numbers are quite that extreme. So we're going to come back and visit this probably the next main meeting, and probably I'm sure cardiac and medical directors, I know education is going to look at it, and we'll continue to move this forward as we go. And I think that's it from both of our meetings.
Any questions for Dudley? Thank you.
You bet.
Injury prevention says Rick Moore on the agenda, but it should be Shelley Stevens Stidham.
Thank you. I'm not Rick. I'm going to try and do my best to lead the committee in 2012 as well as Rick did. Had the privilege of serving on the GETAC Injury Prevention Committee for the last 3.5 years. I'm the director of the Injury Prevention Center of Greater Dallas. So for 2012, what the Injury Prevention Committee is going to be focusing on is strategic planning. Over the last couple of years, there have been some national organizations, injury prevention organizations and trauma, that have visited, made site visits to the state of Texas and have recommended injury prevention strategic planning efforts and things like that. So the GETAC Injury Prevention Committee is going to take that on this year. To that end, we've scheduled 4 workday meetings in addition to the regular GETAC meetings. So we had our first workday meeting in Houston on January 27th. And our plan then was, or our goal for that meeting was to develop the outline for the strategic plan, a vision statement, a mission statement. Wanted to include some background information, mortality and morbidity information. Been getting really good state level and RAC level data from Tammy Sajak and her staff that we're going to use for the plan. We also plan to include some past accomplishments of the GETAC Injury Prevention Committee, and then the development of goals and activities, goals and objectives with associated activities. So what we did at the January 27th meeting was come up with and agree on the outline, a vision and mission statement, some goals and objectives, presented that to the group at our meeting on Wednesday, and voted on the vision and mission statement and the outline. Plan to, at our next follow-up meetings, particularly the one, our next workday meeting, which will be April 27th here in Austin, we'll fine-tune the goals and objectives and then start assigning tasks and things like that to the goals and objectives. Our plan is to have the strategic plan completed by the November meeting. We want it to be provide direction for evidence-informed injury and violence prevention strategies, a place where injury and violence programs can go to look for effective and evidence-informed strategies. We're also involving the Texas Trauma Coordinators Forum and TTAF in the development of the plan, because one of the recommendations from the national organizations is that this be a coordinated effort. And so one of our objectives or goals is to try and link the injury and violence prevention network together in Texas, so that we're all on the same page and we're doing collaborative activities as opposed to duplicative or competing activities and things like that. One of the other things that we hope to do is provide a vehicle for training opportunities for injury and violence prevention staff. So we are planning to, there were several opportunities, upcoming opportunities in 2012 that were mentioned at our meeting on Wednesday. We're hoping to be able to post those on the GETAC website. One that I particularly want to mention is that we're planning in conjunction with TTAF and TTCF, the Injury Prevention Committee is planning a Texas Injury and Violence Prevention Conference. This will actually be the second one that's planned. It's going to be held here in Austin on June 20th through 22nd at Dell Children's Medical Center. Dell is hosting it and providing a bulk of the funds. We'll be having several nationally known speakers, including speakers from CDC, who are going to be talking about how to translate the research in injury and violence prevention and translate it and make it applicable to the practice community, those of us who are out in the field and actually doing the activities. Another keynote speaker that we're going to have is Dr. Todd Maxson, who's probably very familiar to this group. Has been at Dell Children's Medical Center and is now at Arkansas Children's Hospital. And Dr. Maxson will be talking about the trauma center's role in injury prevention. And so we're very excited to welcome him back to Austin and Texas for that conference. Are there any questions?
Any questions? Thank you.
Thank you.
Next, we have Medical Directors Committee, and playing the role of Dr. Ellerby will be Dr. Phillips.
I'm honored to be the understudy. We met yesterday. We also were part of the joint meeting with EMS and the Cardiac Care Committee. Lots of really good discussion in that meeting, especially regarding the issues that were presented previously. We also were addressing the Texas Medical Board consideration of perhaps appointing an EMS medical director to their board at some point, and also to outline a designation for EMS medical director and educational requirements and their rules. And they're asking us to participate in some of the reviews as those come up towards the medical board that pertain to EMS medical directors, and several of us have already sent in our willingness to participate in those. They're also discussing the controlled substance diversion issues and how we can try to assist with that. We also had an in-depth discussion and presentation regarding the online medical directors course that the medical board is at least willing to discuss making a requirement as part of their rules for EMS medical directors. We had an update from the TDMS, as well as also from Dr. Morber regarding the catastrophic and pandemic guidelines. That was a real uplifting section of the meeting, if any of y'all were there. We also discussed somewhat at length the interstate issues relating to when especially air providers come into Texas, pick up a patient, and then deliver that patient within the state of Texas, and regarding whether or not they need to have Texas certification and licensure, and that's going to remain an ongoing discussion item for us. And we also discussed the drug shortages and impact of that, and working towards some recommendations and at least getting some guidelines or best practices on how individual agencies can address this. We see this as an ongoing issue. It's not going to get better. It's just going to become more frequent with probably a wider variety of medications. As far as action items, we agreed to allow our proposal regarding the online medical director's course to go to TCEP as far as supporting that. And I believe that Dr. Greenberg's going to take that to their board of directors in April. And then we also did pass a position paper regarding health information exchange, and we will get that to the chair so that that can then be presented probably at the next meeting for GETAC to approve. And then we'll forward future agenda items. Any questions?
Thank you. Pediatric Committee, Dr. Macias.
Hello. The committee met on Wednesday. We started our meeting with committee liaison reports, important because the discussion for standardizing a definition for pediatrics within the trauma committee became a point of discussion for our group. We're delighted to hear the attention to pediatrics, of course, and that definition that they, and I apologize for preempting them, but we're actually ahead of them on the schedule. So the definition that they would propose is up to the 15th birthday. Part of the discussion that we had were the implications that had for regulatory, clinical, and educational initiatives, as many of the evidence-based approaches cross that age range. So what we resolved within our committee is to support a definition as they're proposing for research and statistical purposes. We'd like an opportunity to explore what that means for regulatory, clinical, as well as educational initiatives. And so I would leave it at that for that point. But again, we commend them for addressing the pediatric issue. In terms of other items, the work that we do in conjunction with the Emergency Medical Services for Children Partnership, we had an update that really focuses on a number of areas that I won't repeat what was given in the EMS portion regarding the provider survey and medical director survey, but I did want to emphasize that the 2009 equipment for ambulances statement, as supported by the American College of Surgeons, the American College of Emergency Physicians, and AEMSP, as well as the American Academy of Pediatrics, is being readdressed, and so there'll be a new consensus statement. There's online opportunities to provide feedback. There are a number of items on there that we consider to be a little bit prescriptive in the recommended list. A number of items that have become antiquated as evidence has shifted, as an example, meconium aspirators. We will be aggregating our responses, forwarding them to the state partnership. We certainly would encourage any of the other committees, as well as GETAC, to forward their perceptions of specific questions and recommendations for consideration by that national consensus panel. Essential Pediatric Airway Project, the EMS group reported on that previously. Just a reminder that all of that is being distributed, primarily neonatal BVMs and pediatric colorimetric end-tidal CO2 detectors through the RECs. There's no particular deadline at this point, but be looking for that information. Education, they continue to develop online modules and have at least 6 regional CE programs to date. A very exciting program for evidence-based pediatric protocol development that was done as an extension of EMSC funding, funded through special projects from the federal agency. We have 4 initiatives currently underway and hope to have those completed by the end of the year. Again, through that funding, a non-trauma shock protocol, a non-transport protocol, C-spine immobilization, and a post-resuscitation management. The commitment is for 3 of those. A little uncertain as to whether the 4th will be achieved within that time frame and with those resources. And then finally, some discussion 2 other EMSC partnership issues. The regionalized systems of care categorization, which I'll pull from the later part of the minutes, but that actually refers to 2 components. One that we had previously described as an effort to work for towards a grant proposal that was looking at a regionalization of care demonstration project. So similar to the program that was adopted by Arizona, the scope of the project that we were attempting in West Texas, because of the vast populations, because of the wide variation, was just not going to be possible given the small amount of monies and the large amount of investment in time and resources. So they did withdraw from that effort. However, the concept of designation of pediatric centers has evolved for us and will become one of our major initiatives. To that end, they brought in Tommy St. Mars from the Arizona program. She's the MSC program director there, who have successfully adopted a pediatric emergency department designation program that resides within a public-private partnership in the American Academy of Pediatrics there. It's been very successful in its initiation. It's not prescriptive at all, but really designed very much in the format of a quality collaborative. So be looking for a lot of that discussion, as that will become one of our major initiatives. We had a child fatality team review update that we work in partnership with. We have there are currently 73 teams up to 206 counties have teams. That's 94.4%, continuing to work with the pediatric subcommittee as well as the RACs to close that gap. And then finally, we had a discussion for pediatric imaging position statement, the concern being, of course, that as we evolve our trauma systems, more and more ionizing radiation has been being delivered to children. The most recent evidence that we know is that there are approximately 500 pediatric cancer deaths, not cases, but deaths, associated with every 600,000 abdominal CTs that are done. So the scope of the project is very significant, considering the kinds of volumes that we see for trauma specifically, but really for all emergency department initiatives. So our subcommittee will take on a role in developing a position statement for minimizing pediatric ionizing radiation. It will really be supported by 4 planks: the importance of avoiding protocols that automatically increase multiple CT scans, avoiding further imaging once a decision to transfer definitive care is made, the use of pediatric dose reduction protocols for process of imaging, and the avoidance of repeating scans unnecessarily unless they are supported by the specific clinical conditions. So as part of that, we will have a document to vet before the group, and we'll hopefully have something to this committee for endorsement at either the next meeting or the subsequent meeting. With that being said, there are no specific action items other than consideration of the limitations of a definition and opportunity to look at other implications for pediatric definition in trauma settings.
Okay, so for the next council agenda, you're going to have a proposal for that definition?
I think you're going to have a proposal for that definition from the trauma committee. We endorse that definition.
Okay.
We'd like the opportunity to also provide caveats for its implications. So we see that as a two-phase definition.
Thank you.
Thanks.
Stroke Committee, Dr. Rutledge.
Good morning. We met Wednesday, and our first item was we have liaisons that are going to start coming to the other committees or came to the committees this session. The point of these stroke liaisons is to solicit needs from the other committees and to facilitate passing information back and forth. And if they haven't come to your committee, I hope you see them next time. Next up as an item is Level 1 Comprehensive Stroke Center Certification. There are 2 organizations that are starting to do certification. One, DNV, starting in March, and Joint Commission starting in July. Previously, the Stroke Committee, this committee, and the TCCVDS at the Department of State Health Services has made recommendations for the criteria to accept for certification of comprehensive stroke centers. Now that certification is upon us, Jane Guerrero from the Department of State Health Services has asked us to review those certifications and make recommendations if we approve those organizations and their certification process. The reason this is important, if you remember, is the state stroke transport plan mandates transporting stroke patients to the highest level stroke center with a recommendation of no more than a 15-minute delay. So starting sometime in July and later, we'll have a 3-tier system with stroke support facilities, primary stroke facilities, and comprehensive stroke facilities, very similar and designed to be very similar to the trauma system. So I think that's very significant and very exciting. Our next item was we have a work group that is working on an EMS stroke education program. And I don't know if they've had a chance to liaison to the education committee or not, but their original or their first recommendation is that in the renewal requirements, CE requirements, that the paramedics receive 4 hours over 4 years, the intermediates 3 hours over 4 years, the EMTs 2 hours over 4 years, and the ECAs just 1 hour over 4 years. The plan is to try to develop an instrument that would be free and easy that then could be used by the education committee and the medical directors to do their stroke education. Right now there are instruments out there that can be used, but sometimes they're difficult or you have to pay money for it. So our hope is to develop something fast, easy, and that works for everyone. And they're going to come back. This is a process. They're going to come back at our next meeting. Our next item was Wanda Helgeson from the Border Regional Advisory Council presented their public stroke awareness program. As many of you know, one of the big issues with stroke is people don't come to hospital because there's no pain, and they miss their window for treatment. And so they've been working on a program and methodology to try to increase that in their region, and they shared that with everyone as a best example. Our next item was Dick Huey from STRAC presented their data on TPA usage. STRAC, as you guys may or may not know, was sort of the last to sort of come into the stroke EMS world, but they have come in with a fierce force. They do a very high treatment ratio for eligible patients and giving them TPA, and he gave a very good presentation on how they were able to achieve that, and they've done an outstanding job. We have no action items to recommend to this committee at this time, but we probably will at the next meeting. And I'm open for any questions.
Any questions? Go ahead.
So, Dr. Rutledge, many people in the audience know I've had atrial fibrillation, paroxysmal atrial fibrillation for the past 2 decades. I was doing some last-minute Christmas shopping on December 21st when really the world became really blurry. When I had meaningful consciousness, which was a really short period of time, I realized I had a right hemiparesis and expressive aphasia. My daughter was home, and I had difficulty communicating what was going on, but I initially said, I was trying to say, take me to the hospital, and I said, I need to go home. Then I was trying to say, I need a doctor, and I said, I need my friends. Then I said, I was getting better. Then I said, I need a neurologist. She was trying to sort all that out. My friends aren't really neurologists, and so she was trying to make sense of all that. It's true.
They may be now.
So So eventually, I could get the words out that I'm either having a stroke or a seizure, and she called 911. And I was transported promptly to a designated stroke center. I got TPA probably within an hour of symptoms. You know, I was discharged 3 days later, and I'm doing pretty well. I think my brain works about as well as it did before. So I really want to say thank you to, I've thanked all the people locally, but I want to say thank you to those of you who've really worked on building a stroke system and improving stroke care for patients. It really makes a difference, and I'm very blessed, and I thank you very much.
Yeah. You're welcome, and I mean, it does work. I can't take credit, but I mean, it really does work, and I hope you're on Pradaxa now. So, but I did forget one other thing.
So the trauma centers need to be ready, you know.
Yeah. There's one other thing I forgot. The TCCVDS, the Texas Council for Cardiovascular Disease and Stroke, is working on a free, simple stroke database. Part of the requirements to fulfill certification for stroke center designation in our state is to submit to a registry, although registry has different meanings in a state capacity. And so we're developing a database, which would be a web-initiated database where people can put in their data for free, and it's very fast and quick, and we'll hopefully have that for people to see next quarter.
Okay. Thank you.
Thanks.
Hey, Vance?
Yes.
I do want to say one thing about
Dr. Stewart, to you.
For those of you, buddy. It wasn't really funny. It got very serious, but as he's getting better, the speech therapist comes and does the evaluation, he's talking, and she says, as she finishes, she says, well, you know, I can tell that you're sort of searching for a word, and you can't quite find it, you go to another word, and I can tell that's there. And I said, oh, no, he's done that for 20 years. You're going to evaluate that.
I was going to say, Dr. Stewart, we're glad you're here, and I think they made you better and faster, so. We'd like to
Too
hear.
bad I don't have a lot of words like some people.
Swish.
Moving right along, Trauma Systems Committee, Jory Klein.
Good morning. The Trauma System Committee met on Wednesday. We had a follow-up or in-between meeting on January the 24th and 25th, and so the PowerPoint that you see is a accumulation or a combination of the meeting that we had in November and the meeting in January, and then the end results that we had in the February meeting. And so our goal is to try to address 5 major issues. And so the first issue is the performance standards for trauma centers and PI. That issue we did bring forward. We would like for the trauma coordinators, the trauma medical directors, and another group to look at that before it's brought forward for action. The second issue that we looked at was registry validation, and we presented some significant data at the November meeting regarding injury in Texas, the top 5 E-codes, the 4 most common E-codes, and the mortality, and looking at the age breakdown and the injury severity scores. And so we identified from that there's a tremendous need to look at the data that's entered into the registry, because a lot of the data was invalid. For example, there were 450 patients that didn't have complete data, so we had to pull them out of the registry. In addition to that, there were a number of patients that were classified over 104 years of age. I think we all know if you were 130 years old in the state of Texas, you'd probably be in the Guinness Book of World Records. So we really felt like there needed to be some standards established for data management. And so the one recommendation was that when data is entered to the state does a warning, and then they do an error report. When that report goes back to the trauma centers, in our current world, there is no follow-up and no accountability for that. And so we would like to see some of the language change that the trauma centers are required to address that and resubmit correct data within 30 days. So that was the first major issue. In addition to that, when we look at the processes of the data, the validation before it goes to the registry, we would like to see stronger language with that, as well as some of the language tightened up on the role of the registrar and the role of the trauma program manager regarding education. So that was the first action. The next two items were sort of a combination. We looked at that data, and in our current trauma center criteria, we have nothing that addresses specifically the geriatric population. And so we felt like we should add some language specifically to geriatric trauma. We did that. We came up with some very brief criteria to add to the current level 3 and the level 4 criteria language. After we did that, the pediatric groups felt like we should do the same for the pediatric population. And if you look at it, there's copies out on the desk for anybody in the audience that would like to get a copy as well. The intent is to implant that into the level 3 and the level 4. So if you are admitting geriatric patients, you are admitting pediatric patients, you will be held accountable for compliance to that particular criteria. So that was the second item that we looked at. The third, actually the fourth item that we looked at was injury prevention activities. Based on those top E-codes that we identified, we went through a laundry list of potential opportunities for injury prevention. And so again, we wanted to partner with, or have the partnerships that are developed with the Texas Trauma Coordinators Forum, TTAF, and the Injury Prevention Committee tackle those and begin to develop CAN programs that the trauma centers and EMS agencies and other individuals could take out and utilize in their community. And then the last issue that we discussed, and it's sort of still an open action, we would really like for GETAC to take ownership of this, is the number of DWIs in the state of Texas. Again, we continue to kill more people in the state of Texas on an annual basis than the number of individuals that were lost in the United States in the war across the waters. And so the issue is, and I just challenge you, we know this information, and yet it continues to be ignored. If you look in our trauma center, if you look in your world, if you know that there's a problem, we're held accountable to fix it. So the question is, how can we bring forces together throughout the state of Texas, from law enforcement, legal systems, MAD, people like you and I together to address this issue? So we would like to see if there's an opportunity for GETAC to ask the governor to form a specific committee or task force work group in the state of Texas with all of those disciplines to address the DWI impact for the citizens of Texas. That's the Trauma Systems Report. May I answer any questions?
Do you have specific action items to go on our agenda for next time?
Oh, I do have one other thing to bring up, if you'll just let me. The RAC presented their RAC criteria, and the Trauma Systems Committee did adopt that, voted to approve it. We would like for GETAC again to consider that for approval. And the other issue we'd like for you to consider, and I'll ask Wanda to come up here, is the urgency to move forward with the RAC criteria. The RACs have gone way beyond just working with trauma. Again, there's strokes, the cardiac, and the many other things as an emergency preparedness. And so they really need to have more accountability, more teeth, more infrastructure in the system of Texas to be able to do their job. So Wanda, you want to comment on that?
She's coming up for a report next, if that's all right. Okay, and I'm sorry, what were the specific action items that need to go on our agenda for next time?
The issues that we would like for you to take action on are the registry validation, the geriatric and the pediatric, and by the way, we did define that the age for geriatric is 65 and older, and we did vote and approve that the pediatric age is 15 and below. We would also like for you to adopt and endorse the injury prevention items that you see listed, and again, ask that specifically to be moved to the coalition that's developed between TTAF, the TTCF, and the Injury Prevention Committee. And then the DWI issue.
Thank you. Any questions for Jory?
I had a quick comment, if that's okay. I wanted to actually just publicly thank the pediatrics and trauma committees and everybody else involved in trying to define that age in pediatrics. That's a very thorny issue as to what constitutes a pediatric patient sometimes. At Dell, for example, 14 and 364, that's, so 15 or less, essentially. So my hat's off to you guys for taking that issue on, because I know that it can be difficult. And the other thing is, when I was a medical student not that long ago, Dr. Stewart was my attending on the trauma service rotation, and I think you're just as chipper and wild as ever. So I'm glad you're doing well.
For clarification, you said 15 and under, and you basically said under 15. Which one is it?
That's an institutional thing for us personally.
That's right.
And that's what I'm getting at. I'm glad that you guys are addressing that. But for us, it's 14 and 364.
Right. So it's under 15. Right. You said 15 and under. Which one are we going with?
I think the group said it's up to their 15th birthday. Is that correct?
Okay, so that's
right. That's
under 15.
Once they've had their 15th birthday, they are an adult.
Right, exactly.
And I know it sounds stupid, but when you get that 15-year-old that shows up, then
not at all. That's a very good point, because it's hard.
Yeah, we're struggling with that where I'm at now, because we're actually talking about going up to 18. We do need some standardization for what that definition is.
So the challenge will be, it's 14, 364, and there was a lot of comments, and I'm sure you'll hear a lot of comments later, that some of the RACs are challenged with that, some of the institutions. So our goal, and actually, is Sally Snow in the room? I applaud Sally for standing up in the back and say, let's just do it. But the bottom line is, we wanted to provide some infrastructure for the state to be able to move forward.
I have a question, Chief.
Go ahead.
There was some sidebar discussion as well. I know that you're defining a trauma patient. Is there any indication that each of the other subspecialties have identified an age group? And I guess my question is, if you have various ages for different chief complaints or whatever, especially when you start dealing with a pre-hospital setting, it becomes a matrices of being able to determine where the patient is most appropriate. Mm-hmm. So there was a discussion of, and I applaud that there was a definition for the trauma patient, but what are we going to then start trying to address it at the other subspecialty levels to try to get some sort of a standardization, because it can be very confusing, especially when you get into the regional fight. Right. Regarding and the transfer from a smaller city to a larger city and those things. So could this be momentum in the direction of some sort of a matrices that's identified by the other subspecialties?
I would think it might be. I mean, I can tell you from our experience here, for example, and when Dell got up and running, from the trauma aspect, Todd Maxson was very much involved, and Todd was able to get all the different subspecialties together and say, what are we defining for trauma? So that got taken care of. In terms of other subspecialties, we sort of built a consensus about what comes to Dell and what doesn't. And I would imagine it's probably, we can give the guidelines, and I think that in the end it's sort of an institutional decision as to how far things go. But most centers will say up to 18 for general medical problems, but then you're right, you get sort of specific cutoffs about, well, if you have a trauma patient, it's up to 15. If you have an obstetrical patient, it's never. So for us, we had that many hours of discussions about who goes where, and EMS, Austin Travis County, EMS, Williamson County, Hayes County, all the counties that Dell serves, and there's over 50 of them. We got together and said, this is what we're looking at, what do you think? And they got input from all the stakeholders, and the consensus was reached. So I see what you're saying. It can be confusing and it can be time consuming, but with cooperation and statements that give you some guidelines, I think it's a feasible thing to do.
I would also point out that in that same discussion, though, some of this is out of our control, because especially for medicine doctors, their malpractice will not cover them for people that are between the ages of 15 and 18, and so that's also part of the issues And those are things that we're not going to be able to address, nor should we in some instances.
And the nice thing about that too is that we recognize it too, and so sometimes you say, listen, I know this person's 18 or 17, but there's medicine may not be able to do that for those reasons, and we say, okay, we'll take them, we'll just do it.
So probably we should continue this discussion somewhere else, but I think that's a myth. I'll just say I think that's a myth of malpractice coverage, particularly in the state of Texas, who has tort reform. I just think it puts the patient in the middle, and I've gone through it with my own. Running a department of surgery is a bit like running a cemetery, in that you have a whole bunch of people underneath you, but nobody seems to be listening. So I would say some of you might be able to relate. The bottom line is that I think that's just commonly used as an excuse for people not to provide the care. And I think a lot of people, when they're saying that, don't even know what their malpractice covers. But I can tell you what it does cover. It covers anyone. If you have someone with an acute problem, whether I'm a pediatrician treating a 70-year-old, you're going to be covered. That's covered under pure statute in the Texas under Good Samaritan. So I'm highly skeptical of all those reasons. But
That's not Good Samaritan.
whatever it's called.
It's not Good Samaritan.
The bottom line, I'm going to tell you, I practice every day, right? Well, I haven't for about the past 6 weeks, but the bottom line is that most people, not talking, I don't know what yours is, but most people's malpractice covers them when they're doing what the reasonable physician would do. It's not based on what the reasonable trauma surgeon would do. It's the reasonable physician standard.
Well, provided that they're not expecting to be reimbursed for that care, would be Good Samaritan. But I understand what you're saying, and I think that probably my opinion would be that perhaps one of the other committees, such as cardiac care, could explore some of this as far as what their cutoffs would be for internal medicine, because they deal with that particular specialty type area. I know as an emergency physician, I'm covered for cradle to grave.
Just to expand on a little bit, our children's hospital uses 14 and under for trauma and 17 and under for medical. Is that because I think that's the part that we are discussing here too. I think it would be helpful if there was kind of a state recommendation, not no rule, but just a kind of recommendation, because this is something everybody's struggling with.
So that needs to be a point of discussion because the recommendation from Trauma Systems is to basically put this into as a criteria in the trauma rules. I guess you started all this by asking if we could expand it to other specialty areas, but that's basically going to be the recommendation.
Okay. All right, we have GETAC liaison summary reports. TTAF, Dinah.
Good morning, Mr. Chair and committee members. Thank y'all for allowing TTAF to have a little time on y'all's agenda. As you all know, we continue to webcast. Unfortunately, because of the response, our website has been having some glitches. The good thing is everything will be there archived, so if you haven't been able to watch anything live, you can always go back. We will continue to work through that. It's very frustrating. You think you have everything ready to go, and then something like that happens. But we appreciate, and we've been very pleased with just the response. The viewership continues to grow, and I was really pleased to see that at this particular meeting, the last several days, that so many of the chairs have been filled behind me as well. So I think that we're growing the viewership and people are still coming, I think is a win-win for everybody. TTAF, we have jumped into the grant world. We submitted our first application in January for the CMS Healthcare Innovation Challenge Grant. It's a very competitive, significant grant that we have jumped into with the help of a grant writer developer. We will find out hopefully in March if we will get that or not, and whether we do or not, we will continue to look for other opportunities. And I think the important thing, as we move forward, the application we submitted is regarding the geriatric healthcare system and looking at the overlay of the trauma, stroke, and cardiac systems that we all work with. And so using what we have currently and building those systems with additional dollars that might come from the federal government or other entities. So as we move forward, if there are opportunities that you hear of, ideas that you have for grants, I hope that y'all will think of TTAF as possibly that umbrella that can help to distribute those dollars back to the state and all the local entities to make our systems stronger. I think this is very important, especially in the day and age that we live in, where state dollars directly to the trauma system or stroke system or STEMI, EMS, are just harder and harder to come by, that we have got to look for other sources. And so we're excited about Dr. Dan Kulika, who's come on and is assisting us with those grant opportunities. We also have a communications person that will be helping us get our messages out a little bit better. And I also wanted to report on the Trauma Systems Division of TTAF. They've been working long and hard on an administrator's manual. That manual is close to being distributed. It will be sent to all hospitals, basically explaining to a hospital administrator, what is the trauma system, why do I want to be involved, what's the cost, just all the ins and outs. And we're very hopeful that this will be something of real value back to the trauma system. Once our TTAF website is up, hopefully in the next little bit, I want to encourage you, we are going to start having more direct communications, and on the TTAF website there is an opportunity to log in, and so you can get any information. You can select different areas that you'd like to receive information. So if you haven't done that, we encourage you to do that. That's all I have for my report. I'm happy to answer any questions, and again, appreciate your support.
Some might understand the broadcast of these has been so popular it caused your website to crash.
That's what we'll blame it on.
Okay, all right. It works for me. Thank you very much for broadcasting these again. I know there's lots of people that can't make it here, and it's very much appreciated.
Well, thank you. And I think just to make sure, these will be archived. If you look on the website when it's up, on the far right column, there's a link to go in, and you can view any of the previous meetings that have taken place. So that is there, and it should be there all the time, and hopefully back up any minute. Thank you.
Thank you.
And thank you to Jason and Russell, who are hiding over here in the corner.
Updated report on the RAC task force. Wanda?
Good morning. Thank you. We had a couple of charges to review the ACS recommendations and also to review the RAC components of 157. As you will recall, the ACS recommendations had a lot of comments about the regional systems and how the RACs should do this and the RACs should do that. So we did provide feedback on those rules and what we thought was doable and what we thought would have to wait. It did, however, influence some of our review when we began looking at Rule 157.123. We also looked at the associated rules and found, as an example, in the definitions, the RACs were not even included in the definitions. So we have recommended some changes there, and a lot of the changes that we recommended to the rule had to do with the overall structure, which was how to become a RAC, which we felt like we had gotten that far, but there was not a lot on how to move forward. So some of our recommendations had to do with changing the current structure so that it reflected more of the model trauma system plan, which will require ongoing work from us and provide some guidance on where we need to go in the future. We also felt that there needed to be more language in the rule that identified the roles, responsibility, and authority of the RACs. You've heard a number of reports today about we're going to ask the RACs to help us with this and we're going to ask the RACs to do that. Well, in some of the cases, there really is not authority to do some of those things. So we believe that that absolutely needs to be strengthened. So much so, moving off of what Jory said, is that we believe that we need to work with DSHS on some interim steps. As I understand it from Jane, we're probably not going to see the rule changes that we're working on until 2014. And for us to move forward with some of the initiatives with not only trauma, but with stroke and cardiac and some of the pediatric initiatives, there need to be some interim steps taken to assure that we're able to move forward with those. One of the things that we would like you to consider is, and I know you're in your strategic planning, is the creation of a formal RAC committee. There are lots of recommendations of things that all of the committees need the RACs to do, and we need to have a venue where all of those go, where we can consolidate those, create an actual plan for those to be rolled out across the state, where there is some prioritization of those projects, and we believe that that would be the way to do that. Questions for me?
Any questions? Just to clarify, so the council gave you the 2 charges. Have you completed those, or you need to meet some more?
We believe we will need to continue to meet for the rule revision as that moves forward.
Okay. All right. Thank you.
Thank you.
Okay, at this time, we're going to review the strategic plan document that we developed last October, and I'm going to need technical assistance with the PowerPoint slide. I don't know. We're going to take about a 3.5-minute stretch while we load up the PowerPoint slides.
Excellent.
good input.
And also release subdivisions. Yeah, you'd have to, and you would actually have to do your. Sorry about that.
I'm sorry about that. Judge, how are you? Nice to see you. And just one note on the agenda. You might just mention that it was done in 2011. Oh, okay. Sorry about this. I apologize. That's okay. That's all right. I haven't made any other changes except what you received. I didn't stick the accents in. Not that I may not even be aware of those. Hey, no, it's not better. The rest of the We do have a list of them. We have a list of what they are, but not the. All right. Sorry about that. It's okay.
Yeah, so I mean, what I'm supposed to, my recollection of what I'm supposed to do is work on the strategic, the trauma and EMS system, strategic plan for the next year, and then am I supposed to do something anywhere else?
Because I came up with a way to do. I've got a.
Who's in charge of streamlining the committees? Us. Us, I know, but we signed it. Me was on that list. I thought I was on the. Uh-oh.
It looks like I'm taking a review of all committees from my optimal number of committees. That looks like Don, Mike, and Nick.
I'm on the, put the strategic plan together, right?
Update the Texas.
Which I think I'm already delinquent for starting the process.
Me too. So we'll go down together.
I got a proof on your desk in front of you saying that shows all the we do have a back door, so that's good. It's up to you.
I'm kind of thinking maybe that we need a session today. Especially posting meeting and stuff, discussion level, we can talk.
I wonder whether we can do that as a go-to-meeting webinar.
That kind of stuff seems like that's kind of hard for me.
How you doing?
See it?
Good to see you, too. I didn't mean to go for the soapbox. Final back to these, where that comes an issue in mind of is a 17-year-old patient with full cystitis or actually 12 pills. And I have people all the time who say, I can't operate it because of I said, that's not true.
Just depends on the size. I know that the cooks are and I didn't even know that. You'll get those copies like that. It's weird. Yeah, I don't know blank, but it's some medicine. All right. Sure. I'm going to see our patient. So that's why, trauma stuff, that's actually very easy. Yeah, for the most part, I mean, for a while,
Time they start yelling. because it's whatever it is, goal B, we'll deal with it then. So. Okay, if y'all wouldn't mind coming back in and taking your seats, we'll get started. I'm so glad you're doing well. I didn't know that you had that episode. That you're telling your daughter to do were right. It was just different words.
If it was still working, I'd be like,
That's cruel and unusual punishment. That's
the peanut butter ones are open, which I like.
Oh my god.
You want one?
No, I'm good.
Do you like one?
I get no respect.
No, I'm trying to eat better.
All right.
Not successfully.
I am too.
There, I changed my
Ladies and gentlemen, we'd like to get started, please.
We'd like to get started so we can get finished.
There you go. Aren't we near cheer time?
We're 37 minutes, 10, 9, 8, 7, 4.
Right. I went ahead and moved so that when we make this presentation, my back's not to the screen and I can follow where the slides are going. And probably about 2 minutes into this is when we'll have the big cheering section thing, so we may have to take another brief pause. The council met on the agenda. It says October 26 to 28 of 2010. That was really 2011, which was last fall. The council had a strategic planning retreat, and I want to again emphasize this is a strategic plan for the council and how the council and the committees and how basically things are going to go procedurally wise in the future. This is not the plan, the EMS trauma systems plan for the state of Texas, although that is one of our goals. This is for the council. I have John Leidecker over here. He was the facilitator for the process, and I thought I saw Martha back there, also helped us out. And so what we decided, the purpose of the retreat and the planning was the need to develop a GETAC strategic plan, discuss the scope of that plan, and we're going to also discuss the process, how we got to the plan, go over the 10 goals we identified and that were actually adopted at that retreat, and then we're going to discuss the implementation of the plan as we move forward. Next slide. The first part of the process was reasons for creating the plan. We needed to look at what our core responsibilities were. There is actually a piece of legislation that created the council and gave us specific charges, responsibilities for the work that we're supposed to do. And then we're going to create a strategic plan to support the goals that we would like to achieve during our term of service that supports those core responsibilities. And of course, if you're going to go anywhere, you have to have a blueprint or plan of action for how you're going to get there. And then most importantly, for the strategic plan for the council, we want to have a mechanism so that it's updated. I believe we chose every 2 years so that as we move through this change, and changes in our environment and what GETAC is touching on will be successful and not be stuck in what we were before. You know, y'all have heard my old tired joke that the only person who likes change is a baby with a wet diaper. I don't. I got one laugh. That's good. I'm to work on delivery a little bit. I don't like change. People don't like change. But my personal belief is if we're not continually changing, we're probably not growing. And GETAC has grown and grown over the years, ever since I came on the council. So we need this plan to help us adapt and grow with the system. So next slide, please. So our strategic plan that we've developed, or still actually developing, it runs from January 1st of 2012 up until December 31st of 2013. It's a 2-year process, and we'll review it and update it every 2 years. Some of those goals and activities we identified are internally facing, basically to support our operations as a council. Others are externally facing to support our mandate that we've been given by the legislature. And then activities in which the council has statutory rulemaking authority to undertake. And that was right on time. Anyway, we do have the recommendations that as a council that we make to the Department of Health. And that has to do with certain rules that we make and certain statutory changes. So Probably if we keep the door closed, we'll manage to do it. And then lastly, as I mentioned before, this is not the state's EMS and trauma services plan. This is for us as a council to operate. Next slide, please. Okay, we had a 2.5-day meeting, and again, those are the dates in October.
It's Jory's fault.
I would tell you to lock the doors, but that's not very good coming from a fire chief, so we'll just move on. The meeting, it was an open meeting. We did have a quorum of members present for all the motions and voting activities. Because of some work conflicts, including myself, we did have some people come and go, but we always had a quorum when we voted. And those on that, I believe it was a Friday, we unanimously voted to adopt 10 goals for this 2-year period. Next slide. Many of you are familiar with a SWOT analysis, strengths, weaknesses, opportunities, and threats. And we identified areas that we're going to devote attention to during the coming 2 years. The strengths that we identified were a strong, dedicated, and committed council membership and the stakeholder community, as evidenced by the great attendance that we've seen at the committees, by the heavy involvement at the committee level. The stakeholders are very, very involved, and that is a true strength that we have that many people caring. The opportunities we discovered were we need to clearly define and focus on our council activities and operations. We've experienced under weaknesses a little bit of mission creep, and we need to focus better on our legislative charge. The legislation created the council. The governor appoints the council. The council is the ones that need to make the recommendations to DSHs. And I think if we go back and focus on those charges in that legislation, we've probably gone a little bit outside of that. Not that that wasn't a healthy discussion, not that it's not needed, but we need to make sure that as a council we're focusing on that original intent of that legislation. A threat to us includes meeting that legislative mandate while considering divergent stakeholder views. And that's a politically correct way of saying everybody's got different ideas about what the council should be doing or shouldn't be doing. And then lots of different viewpoints on, as I've mentioned to you many times, we're all on this journey together. And so even though we love and respect each other on this journey together, we do have different views, and different stakeholders have different agendas. Next slide. So we decided to create these goals, and so we needed a framework, and that framework had to answer these questions. Now, not all goals that we created could be answered by answering these questions, but we want to know if it's doable, if it's smart, and I'm not smart enough to remember what all those were, but specific and measurable and timely and those kinds of things that make up that SMART. Is that too distracting, or should I continue? Okay. We've lost enough to out-yell them, so we're going to keep going. Can our goal be explained, and can it be defined? And do we have statutory or rulemaking authority to conduct this goal? I think that's a kind of a key issue for us as we move forward, and including some of the things that we've done. We need to make sure that we do have that rulemaking authority. Is the goal relevant to the mission of GETAC, which I read at the start of the meeting? And will it improve patient care, and does the goal improve care at a systems level? Next slide. So then we identified these goals. They're in no particular order. Develop a framework to apply, and for each of these goals, we have an action plan, who's responsible from the council, when we plan to get it done, and how we plan to get there. The framework to apply our vision and mission to all decisions made by the council. For example, the action plan was, as we did today, the chair reads the vision and mission at the start of the meeting, so that as the council votes and makes decisions on that, we're following what our original vision and mission and intent was. I'm doing a great presentation with all that clapping. I'm telling you, I'm going to keep. They're liking it. All right, I'm going. We're going to increase collaboration between the council and the stakeholders involved in EMS and trauma. I believe Remy came up at one point. I think I see her in the audience, and said we needed to improve our communication, bring outreach, bring more people in. This is along those lines. We're going to undertake a review of all committees to divine the optimal number based on the need, et cetera. And we know this is a touchy subject, but it's the what you call it's the elephant in the room, but it's got to be addressed. and we're going to do that. We have a subcommittee to work on that. We need to improve the operation of the committees. None of these comments are intended to say that the work that the committees is doing is not good work or even great work. We're talking about a process improvement for council and the way it operates. Of course, we need to update the existing EMS and trauma plan. That's the statewide plan. That's one of our goals. And we want to improve the communication between DISHES and GETAC. Again, our role is to advise them. And so we wanted to get basically both sides lay all their cards out onto the table and say, this is what can really happen, this is what really can't happen, here's our intent, what's another way that we can do it together. We also wanted to develop and refine a system for orienting new council members when they're appointed to this council. Some of us actually went through a training program put on by the governor's office, went through all the opens records, laws and meetings, and different members of the governor's staff came in and talked to us, along with many other appointees from other state councils. And some that have been appointed to GTAC never got that opportunity. And so they kind of come in and if you can imagine being fresh and coming right in on this council in the middle of some of these discussions, it can be pretty intimidating. Again, goal H was to conduct a strategic plan review at least every 2 years for the council. We want to partner with organizations to support GTAC activities as necessary. Our partnering with TTAF as they broadcast these meetings is a good example of that, but we think there's a lot more out there. And we would really like to, as a goal, organize the regularly scheduled GTAC business meetings and get it down to 2 days, basically 48 hours. We haven't really nailed that down, but so there's a goal there so that these meetings don't last almost an entire week. We felt that was important based on stakeholder input. I'm just going to touch on some of these. Each goal has an individual action plan that won't be displayed up there. Each action item has a responsibility, who's going to do it from the council, who we're going to partner with, what time we hope to get it done by, and other considerations. And different council members took on different parts of these goals to lead them. The action plan is a living document. Although the council did adopt unanimously all 10 of these goals, the action plans to get there may have to be adjusted depending upon internal or external influences. So we consider it a living document. If we have to change it, we change it, but it's designed to be a framework or a foundation for how we're going to move forward into the future. Is that the last slide? Okay. As we implement the plan over the next 2 years, we'll hear updates from GTAC members. As I said, each of them have been assigned goals. We will put it on the agenda, and then we can let everyone know where we are in the action steps for that goal, whether we needed to change them, or whether they've even been completed. Those will be carried on. So I think that's the last slide. Okay, thank you. What I'm recommending, there's still some work that needs to be done, although the goals have been established. What I can do, if the council would like, I can kind of run through each of the goals and discuss the action steps. And for the audience purposes, is that? Yes, okay, I'm not seeing. My cheering went away, so I'm not sure how I'm doing on the presentation, but anyway, goal A was the vision and mission statement, and really that was just make sure the chair remembers to read those at the beginning of each meeting and remind us as a council that we each represent our different constituent areas, but keep in mind that vision and mission as we make our vote. Increasing collaboration between councils, the council and the stakeholders. The action item is to develop a plan to operationalize collaboration and maintain awareness of issues to include an evaluation and monitoring plan. Jody Harbert and Dr. Greenberg are assigned to that one or volunteered for it. This includes how to include council members in more of the committee activities. We discussed that some of us council members come in on Friday morning and don't have the opportunity to really pop in and see a committee meeting every now and then and see what's going on there. So we're identifying how do we deal with that. And again, we can't have a quorum of us in a committee meeting because then that would be considered an open meeting. So we have to watch that. identify the roles and responsibility of council members in collaborating with other stakeholder groups, and identify the issues that are important to stakeholders, which is something that the council has always tried to do. Under Goal C, which is the committees, we're going to work on a plan to include a review of all existing committees. And for some of you who haven't, many of you I've seen here for years, as it happened over time, Stroke Committee is the only committee that's legislatively mandated. All of the other committees were created by GETAC, and usually, from my experience on the council, was because there was an issue that the council member didn't have the time to invest to handle council activities and handle additional issues. So the committee was created. For example, the Emergency Preparedness Committee came out of a task force or a work group. So all of these committees have generally evolved, not all, but most out of specific issues or areas of interest. So the plan will include a review of all committees to define the optimal number, how many committees do we need to operate efficiently and effectively, the structure of those committees, what their charges are. Again, most of the committees came out of a specific charge. We're asking, here's a committee created, here's what you're charged to go find out and report back to council so that council can make the decision. And we need to review what the charges are for the current existing committees and if they've met the charges or not. Reporting relationships, who does each committee report to, who do the chairs report to, membership on those committees, including things like we have members who have been on the committee since its existence, and we have a lot of stakeholders that would like a shot at being on those committees. And you know, that's an ongoing discussion that's been going on for quite some time. And then the actual decision-making process. How does an item get to a committee? How do they make it? What process does that committee use to reach that decision? And then how does it come back to council for us to reach a decision on? And I guess that's actually part of the action plan for Goal D, which is develop a process to improve the operation of the GETAC committees. That include, after we review all of them, develop a process to improve the operation, identify opportunities for improvement and implement those solutions, and then develop a mechanism for the council to meet prior to committee chairs before the regular GETAC meeting. And council, correct me if I'm wrong, that was a way to perhaps meet with the chairs, discuss the business that will be conducted, and then meet with them afterwards so that we can get a report of what was actually discussed along those lines. Is that okay? And then update the existing EMS trauma system strategic plan, and we'd like to do that every 5 years starting this year. I think the one we have now is either 10 or 11 years old. That was created by the council. To obtain stakeholder input for the EMS and trauma system plan, develop a form for the committee chairs to submit information online by rule, and then individual stakeholders would provide information through the GETAC committee process. So we're looking at it's important to get stakeholder input as we develop this EMS trauma plan, and then develop a proposal for EMS trauma system strategic plan, and then update it. And all of these are underway or about to be underway. Goal F is improve the process of communication between DISHES and GETAC. We're going to develop, as an action item, develop the plan to describe that flow of communications. What does that actually look like? And define the parameters of the communication and what flows and how does it flow, and who does DISHES talk to on committees or councils, and what's the reasoning behind it, and then what happens when a committee member needs to get information. How do they go straight to DISHES, or do they go through some other way to get the information to make that communication more efficient and effective? Also considering the open meetings laws, and we still struggle a little bit with that for the time that I've been on the council, is a true understanding of the open meetings laws and what we can legally do and what we legally can't do. And we just need to make sure that information is continuously out there, because you can accidentally violate open meetings, open records laws, and have no intention of doing it and be completely innocent, but yet violate those laws and get in a lot of trouble. So We're also going to determine which committee is dealing with which issue. Over the years, you hear a different issue comes up, and there's so many different committees that have a stake or a part in that, as they should. And then we get into an issue of dishes has to go to every single committee and repeat the same information sometimes, and it may be a little bit more effective, a little bit more coordinating, so that they don't have to do that. Goal G was, again, that orientation system for new council members. We do a pretty good job, I think, with the committee members as they come on. Usually we hold a training session on the Monday afternoon before the Thanksgiving, I call it the Thanksgiving GETAC meeting. We usually ask new committee members to show up there, and they get a pretty thorough orientation. The action plan was contact the governor's office to determine if orientation process for new council member exists. The governor's office actually called me a couple of weeks ago with a question. I went ahead and asked them about this, and they informed me that they are going to go back to, or have always, I'm not clear on that, had these orientation meetings, and perhaps maybe there was a miscommunication and then members of the council didn't get notified, or it wasn't impressed upon them how important it was that they attend, but they assured me that I'm waiting for them to get back with me a date. So here's an action item of a goal that's already been completed, and we can check that one off. And then if additional steps are needed beyond what the governor's office provides, then we would develop an orientation process for those additional steps. Goal H is conducted GETAC strategic plan review at least every 2 years. And we simply are letting dishes know we'd like to go through the same process we went through in October every 2 years, so that they can look at funding mechanisms for that in the future, and then actually schedule times as far out in advance as we can so that council members can schedule their time so that as many people as possible can make those strategic plan reviews. Goal I is partner with organizations to support GETAC activities as necessary. Action item 1 is conduct a baseline assessment of current partnership activities, which is who are we working with now, how are we working with them. And then secondly, then identify opportunities for increased collaboration based on findings from other goals and activities that are throughout this plan. And Goal J was to organize the regularly scheduled quarterly GETAC business meetings to 2-day meetings. Action item 1 was develop a framework on the current committee structure to identify potential opportunities. And 2, develop the regularly scheduled quarterly business meeting timeline. In other words, take the meetings that are being held now they start Wednesday afternoon, correct? Wednesday evening. Some actually come on Tuesday. And then up through this meeting this morning, and try to condense that down into a 2-day operation. So those are the goals and the action plan. As we go through with this, the council members will be updating the action plan. For example, I just reported to you that the step about the governor's office orientation, check that off. And we will be updating and reporting back to you all as well. We are open to, the goals have been voted on unanimously. If there's things that stakeholders feel are opportunities to improve our action plan or have input into the action plan to get those goals, we're certainly open to them, and many of us on this council will be contacting stakeholders to help us get through this process. And I will open it now for any comments from the council about our strategic plan. One of the things I'd like for council to consider, and we can have this for discussion, is it's another meeting, but have another day-long meeting, come in the morning, go out in the afternoon to workshop and update the action plan and report on it, as opposed to actually working through it during a council meeting. Anyone, one way or the other?
I'm just going to have to. I think if we do that, if we can do that in conjunction with the GETAC meeting, when many of us will already be here, we can do that on a Wednesday or a Tuesday. I think we might kill 2 birds with one stone while we're already here.
Okay. Any other comments? Okay. I will relocate. Jody, I appreciate your comments. I guess one of the things that I was thinking about was, since our meetings are 3 months apart, and since we're initially getting this strategic plan up and running, that maybe we could have one meeting between now and then, and maybe not, we wouldn't have to discuss this every single council meeting or have a separate work day, but just kind of get this formed up a little bit better.
I certainly understand. I think along with that, when we have our 4 regular scheduled meetings, and so many committees now have added 4 more meetings to that, so that's 8 times a year. Certainly, I think it's valid. That's the only way that we'll get something done, because in our hour-and-a-half meetings, you really can't get anything done. So when we have our scheduled work days, I think it might behoove council too if we can schedule this when some committees having their work group, so that we are still, again, if we're going to have to make an extra trip, if we can make that extra trip in conjunction and support of our partners with one of their work groups.
Okay, so I guess the real question is, does anybody object on council to having another work meeting between now and May? And if so, we would try to make it in conjunction with another committee meeting.
I think we do need another day. I understand what Jody's saying, and nobody wants another meeting, but the disadvantage of doing that is we lose our focus. Yep. And I think we probably need a day to focus on nothing but these 10 items. I hate to, all of us hate giving away another day, but I think this is important enough to where we should try to not sequester ourselves, because obviously we can't, but truly just focus on those goals.
Can we do it on a cruise? No, never mind. Okay.
No.
On the
stakeholders like that,
coast.
I saw.
The third coast, yeah.
The work group session we're talking about on the strategic plan is obviously a public meeting, and stakeholders would be invited to attend. Any other comments on the strategic plan?
Will there be any value at holding it in some other place? I mean, spatially?
We'll look at that.
Help me out a little bit.
Well, I mean, the Dallas-Fort Worth Airport, many people that fly Southwest end up going through there to get here. So I didn't know if we could speed the process by potentially looking at the Dallas-Fort Worth area.
Well, we certainly can take a look at that. I'm easy to, it's easy for me to get to Hobby and fly up there pretty easy, so. Okay, now, so the next item on our discussing of this plan is some of the council members have done some work on the strategic plan. Did you want to report on that at this meeting, or just hold it and go into those individual details at the next meeting we have, the work session? Okay.
Yeah, I've worked on the 2-day session, and it'd be at the will of the council if they want to try to bite that sandwich with 10 minutes to go.
Well, there's. Oh, you didn't bring the flak jacket. Okay. Well, you know, if we wait this till the end, there's fewer rifles out there. So, no, there's a timer up here, but we are not. I was joking about that. The producers over here were set it up there. We can go until 2 or 3 in the afternoon if we have to. But come on.
I have it loaded on the computer. It's the will of the council. If they want to see some draft, I'll be happy to show it up there for discussion or just for information. Totally up to the council. All right. Yep.
Okay.
Well, the one, and that's why I think we need a day to discuss all of them. They're so interlinked that you can't talk about one without going back and forth to another.
Okay.
Did I miss it? Did y'all decide when you wanted to do this?
Of course not.
We have not selected
Okay.
a date. No, because we know it's going to take several weeks to get it posted and all that kind of stuff. So. Yes, I'll work with Director Guerrero and send out, these are potential dates, and then you can reply back to her, and that's not a problem.
Thank you.
All right, at this time, we will take general public comment.
Good afternoon.
My name is G.K. Sprinkle, and today I'm representing myself. I have a big concern about adding additional CE categories to the list of categories that you have to meet to get your recertification in Texas under the CE recertification. For one thing, if you're not using a national registry to do it, but you want to maintain or try to maintain national registry, it's really difficult to try and fit these all into different slots. And I'm not even sure what at least one of the different categories is supposed to test. So I keep thinking that you need to make certain categories that might cover these other things and encourage people to go to them. One of the ways I think that you could encourage people to go to it is to have a piece of CE be usable in more than one way. Like at the last conference, you could say a particular session could be for medical or for pediatric, something like that. I tried to select those kinds of categories because it would allow me more flexibility in trying to set it up. I don't think you need to be you have to be a brain surgeon to figure out your CE. And I really think we've just gotten beyond what should be done with CE. Thank you for your time.
I have a question. Which category is it that you don't understand?
Clinically related operations.
Okay.
GK, I will tell you that the Education Committee, along with trying to look at what or how far National Registry is going to play a role, whether we make the transition or not, we've already started looking at how we can make that matrix a little more palatable for National Registry as well as for Texas.
Thank you.
Jory?
Mr. Chair, I have a question specifically directed towards the new development of the new registry. I know that they're moving forward